Richard Turner-Warwick, what precipitated your own and Graham Whiteside's interest in neurodynamics at the Middlesex Hospital?
Well, David, I've always had a personal interest in the relationship of structure to function. And it seems to me, looking back, that the 1960s really heralded the end of the Dark Ages as far as urological investigation is concerned. Before that, you know, urologists felt that by examination endoscopically of the prostate and the bladder neck, the identification of trabeculation, they could actually say whether a patient was obstructed or not. And indeed, in those days, uroflowmetry meant watching the patient pee. Electronic uroflowmetry didn't really come in until the 70s. And yet, it is as important to the accurate diagnosis of urological function as a sphygmomanometer is to cardiology. And indeed, when you have a complicated problem, synchronous video studies are as important as cardiac catheterization is to the cardiologist. But you know, even now, uroflowmetry is underused. Without uroflowmetry, a clinician tends to overdiagnose prostatic obstruction and underdiagnose bladder neck obstruction.
Yes. When you started doing urodynamics at the Middlesex, there was very little of the sophisticated equipment that we have now. What sort of equipment was used and what sort of hard copy did you get at the end of the day?
Yes, well, we originally started the clinic in 1962 in an endeavour to identify function. And then we used a simple voiding cystourethrogram, and we recorded it on 35mm film, and the unit was known as the Cine Clinic. And that was really the beginning and the end of it for about 5 years. But I think it's important to emphasize the value of the simple cystourethrogram. It really is an underused procedure. With this alone and without pressures and flows, we did in fact identify the dysenergic nature of bladder neck contracture. We identified the fact that Marion's disease was really due to a dysenergic bladder neck. We identified the distal sphincter dysenergia and its management by readjustment with the Otis urethratome, the principles of the outlet adjustment to balance up a cystoplasty, and indeed developed colposuspension as a procedure for female incontinence. But you know, I suppose it was about 1968 that the value of synchronous record became apparent. Patrick Bates was appointed as research fellow, and he developed the synchronous studies from the complex research studies that were pioneered by Earl Miller in San Francisco. He developed it as a clinical instrument, and indeed it's to him that we not only owe the basis of this unit as a clinical synchronous study, but also the concept of bladder instability.
Now, all this work that was done in the early stages culminated in you being a guest editor with Graham Whiteside for the North American Clinics in Urology. Do you think that book still holds true today? Do you think it's the Bible of urodynamics? Can we say that?
Well, I don't know about the Bible, but it's certainly referred to as the little red book. But in fact, there aren't many things that was published in 1979, and we really wouldn't withdraw many of the things. We did introduce it with an apologia, suggesting that it might better be called the urodynamics of the urodynamic clinics of South Britain rather than North America, but that's another matter. But you know, in a referral unit, although there's enormous value in synchronous studies, and once you've got the facilities available, it runs efficiently, and it's a great saving of patients' time and doctors' time and instruments' time if you can do everything synchronously. However, it's very important to remember that you can in fact piece together all this urodynamic information, and indeed it is absolutely essential that when you're evaluating a patient, the Euroflow study must be a free flow. The patient must recognize that that is a representative flow, and if it isn't, you've got to do it again. And the reason for this is simply because under the circumstances of the investigation, you cannot possibly expect a patient to give of their normal voiding.
Do you think it's possible to practice modern urology, and I put that in inverted brackets, without urodynamic facilities?
I certainly don't think it's anybody should be allowed to practice functional restoration without using a uroflowmeter. But how far you go beyond that is simply a matter of judgment. I'm often told that, well, of course, we don't have facilities for urodynamics. They mean, of course, synchronous studies. But in fact, as I said, you can get an awful long way with a simple voiding cystourethrogram. Everybody has this. Everybody has a video record, and all you've got to do is to attach a microphone to it in order for it to make sense. Synchronous studies in a referral unit are really very useful for the complex cases, particularly, I think, the evaluation of persistent symptoms after a prostatectomy, for persistent leakage after stress incontinence operations, and of course for the evaluation of neuropathic bladders. I think these are the things where you actually need the sophisticated centre.
Now, we've had the first 20 years of urodynamics of the Middlesex. How do you see our unit and units like ours developing over the next 20 years?
Well, obviously, we've got to the stage of understanding most of the problems that clinically present. There's an enormous amount of work to be done on neuropathic dysfunction, and certainly in a referral unit like ours, the research is going to go on into in-depth studies in small areas of this situation. Obviously, we would like to avoid doing these complex studies, and in many ways, once you understand how things work, you can manage to do without the sophisticated studies. For instance, in children, you don't do synchronous pressure flow studies simply to determine whether somebody has detrusor instability, nor even pressure studies. All you've really got to do is to look at the 24-hour voided volume chart, and the wide variations will tell you immediately where you stand. Yes, I'm sure the future is going to be simplification in some lines, and certainly, as you've seen on the film, we've developed the ultrasound cystodynamigram, which is a totally non-invasive way of assessing function. And we've developed the intravenous urodynamigram, which is far more meaningful than the intravenous urogram, which I regard as an obsolete investigation for most practical purposes, except for the upper urinary tract. You know, in the end, I view research and development in a sort of multi-stage rocket situation. I think one has been extremely fortunate to be in rather at the beginning of urodynamic evaluation. I think one gets to a stage where the first stage rocket begins to tail off a bit. I hope that the shoulders will be there for the second stage rocket, that's to say you and Chris and many colleagues like you, to take off from those. The future is your business.
Richard Turner-Warwick, thank you very much.